Ariane Reeves, and I'm a public health nurse and public health advisor with the Division of Performance Improvement and Field Services at CDC's Center for State, Tribal, Local, and Territorial Support, or SDoH. And I work with the National Network of Public Health Institutes, or NMPHI, on the Public Health Performance Improvement Network. PHPIN is a peer-led learning community for those who work and whose interests include topics related to performance improvement. And this might include public health accreditation, quality improvement, performance management, workforce development, and cross-cutting skills like systems thinking. PHPIN was developed to support you. We have a very active community that is great about sharing and practical solutions and learning together, like today. If you're not a member yet, we would love to have you join us. My colleague Megan Wolf with NMPHI will let you know how to join a bit later. This webinar is part of our learning offerings that provide performance improvement professionals with the skills and tools they need to conduct their vital work during COVID-19. We hope that you'll be active participants in this webinar by chatting in questions and comments during the presentation, and then joining the discussion that will follow today. I'm so happy to welcome today's presenters. With us, we have Jane Chai from Conduit, Inc., Kelly Watkins from the Southern Nevada Health District, and Stacy Zhang from Kane County Health Department in Illinois. Thank you so much for your presentation today. Now it's time for Megan to go over some logistics like the agenda and tell you a bit more about what's going to happen today. Turning it over to you, Megan.
Thanks so much, Ariane. So welcome everyone, and thank you so much for joining today. We have a great group and we'll hopefully have a great discussion with our three presentations. Just a few housekeeping items before I turn it over to Jane. So if you have any technical issues, please feel free to chat me directly. You can change who the chat is going to right there above where you're typing your message. This session is being recorded and will be made available later to those who can't attend. And as Ariane mentioned, we welcome and love questions and comments in the chat during the presentations, and we'll have some time at the end to have a nice discussion. For now, we would be grateful if you remain on mute until the discussion portion, and then you're welcome to unmute and ask questions and make comments and also share your experiences. The mute button is in the bottom left-hand corner. So I'll go ahead and turn it over to Jane to kick off our presentations for today.
Thanks so much, Megan. So yes, my name's Jane Chai, and I'll go ahead and kick off by sharing some of our learning objectives for today. So our objectives were to have a conversation describing some emerging social determinants of health and COVID-19 data, and discuss how health departments are currently using this data for community health planning or performance improvement. For our agenda, we'll have three presentations as mentioned. The first will be from Conduit Healthy Communities Institute, and then two presentations by local health departments in Southern Nevada and Kane County, Illinois. After the presentations, Megan will come back and lead us in some discussion. Our speakers today, as mentioned, will be me, Jane Chai from Healthy Communities Institute, followed by Kelly Watkins, Epidemiology Supervisor at Southern Nevada Health District, and Stacy Kang, Community Health Planner at Kane County Health Department. I'll begin by sharing a little bit of background on myself. I am the community health subject matter expert with Conduit Healthy Communities Institute. I've been in community health for about 20 years, and 15 of those was with Orange County Healthcare Agency, which is actually the local health department serving Orange County, California. And for my last 7 years there, I did serve as the public health accreditation coordinator. So I was responsible for community health planning, performance improvement, strategic planning, quality improvement, workforce development, and as many of you probably are, other duties as assigned. So I joined Healthy Communities Institute in January of last year, and my role is really to bring that expertise from my experience at the health department to what we do at Healthy Communities Institute. So for those of you who aren't familiar with HCI, I thought I'd do a brief introduction. HCI is made up of a team of public health professionals rooted in a mission to help organizations address social determinants of health and improve health in their community and create healthy communities. And over the past 12 years, we've worked with health departments, hospitals, and collaboratives across the country to improve community health. We support community health platforms that provide health, social, and economic data that help communities work together on improving health. And we also help with community health assessments, strategic development, and evaluation. So I actually came to know HCI as a client at the health department, and that's what we used for our community health improvement efforts. I'd like to begin by sharing our approach for choosing meaningful data for community health and performance improvement, since that's what we'll be discussing today. When we select data, we're really looking to find indicators that help us facilitate cross-sector and multi-department collaborations, track progress over time, and get to root causes of health inequities. We like data that align with state or national initiatives, such as Healthy People 2030, because they are more likely to be tracked by multiple organizations and at different levels. We also think it's important to use reliable sources that are regularly published, which helps us track our progress over time. And finally, the data must be granular enough to show disparities. So we find that this is really what informs local programs and policies, is looking at those disparities. I think my colleagues, Kelly and Stacy, will likely go into this a lot more detail about COVID, as they've really been entrenched in this work. But I did want to address COVID and some of the ways we've tailored our work to consider its impact. First, I want to acknowledge that quantitative and secondary data alone doesn't fully capture our community's experiences, especially in light of COVID. So we found that it has been really helpful to supplement that data by holding focus groups or key informant interviews to gain more in-depth insights. I'm showing an example here of a recent community health assessment where we asked questions about the impact of COVID. And I think the results really help the client get a better picture of some of the themes around social determinants of health and COVID that we'll be discussing today. And I get that this might be quite difficult or maybe impossible for health departments to do right now, but you may find that community partners or hospitals might have some bandwidth to assist with this. Another way to consider COVID is by integrating COVID data and viewing them alongside your health or social determinants of health indicators. Here we're seeing how one county is doing on their COVID cases and fatalities on the same dashboard as how they compare for deaths due to stroke or poverty level. Having this all in one place might help bring COVID into the context of your overall community health planning efforts. I'd now like to move on to discussing some of the overall trends we're seeing in community health. First, I think we're seeing that the trends we've been discussing over the past few years have really been reinforced by COVID. And that includes the need to address health equity and social justice as central to our work, underscoring the need to work towards community connection and resilience, and bringing us back to the need to integrate clinical and community health data. So I'll dive into the first one of these. We've really seen an increased demand for data that help show disparities and get to the root causes of health inequities. I must start by saying that many of the community health indicators that we've been focusing on over the past few years are still important for tracking progress and disparities on a community level. I'm sure you're very familiar with the ones I've listed here and may already have them in your plans, but I want to acknowledge that though we're talking about emerging data today, what you're likely already tracking is still very important. COVID has also made us more interested in tracking data around basic needs, especially food insecurity, housing conditions, or internet accessibility. I think the last one was something, internet accessibility is something that I think we knew was important before COVID, but with remote working and learning, we're really recognizing access to internet as a basic need. Finally, we're seeing an interest in looking at data that tracks root causes of health inequities. I think there's no turning away from the fact that racism, poverty, and education are core public health issues. I've listed a few that are of increasing interest, including tracking hate crimes, policing, early childhood education. We're also seeing a renewed interest in using vulnerability or need indices that help synthesize multiple indicators into one value to better direct action at a local level. So the image on the right that you're seeing is HCI Socio Needs Index, which is an example of one of these indices. We've also launched a food insecurity index on our client sites to help them address food access, which is an issue that has been highlighted in this through the COVID epidemic. So I'll take a step back a little bit. I think many of the data points I've just shown might feel too broad for performance improvement internally, and especially those initiatives that are internal. So I want to acknowledge that working with emerging data, especially around social determinants of health, often means looking at performance indicators that measure more process or short-term outcomes. So for example, you might track the number of organizations that you've engaged or the number of trainings that you've completed. So let me get into those measurements a little bit. When I was in Orange County, one way we identified performance indicators for health equity was to conduct a self-assessment. We used the Bay Area Regional Health Inequities Initiative, or BARHI assessment. Incorporated this into our biannual workforce development survey to establish a baseline. And to track our health equity efforts, we then worked on increasing the number of staff who completed a health equity training or the number of programs that were engaging residents for program planning. Another item we worked on was moving towards data standards that better supported health equity. The health department is a key source of data for community partners. We realized that we really needed to standardize how we collected, analyzed, and presented data so that they could better be used for health equity initiatives internally and by our community partners. So we formed a work group to develop these standards. I'll note that race, ethnicity, gender, and age were relatively easy to define. Relatively easy, I'll emphasize, but we really had to spend time to define standards for gender identity and sexual orientation data that our community had really been asking for. And after we did this, the next step was to track implementation of the standards. So how many programs were using them? How many reports displayed data in this way? So I've included some resources for data collection here that we found helpful. I'm going to move into the next notable trend we're seeing, especially with COVID, which is the importance of tracking data around connection and resilience. This includes measuring resources related to trust, trauma, isolation, and community resilience. Though interest is quite strong here, I think many of the tools and data that I'll be sharing has been a little more difficult to define. When I mentioned resilience and trauma, I think one of the more prominent movements has been around ACEs, or adverse childhood events. And I won't have time to go into detail about this, but I know there's been quite a lot of work around this topic, and it's been an important way for us to measure community trauma and work towards resilience. CDC's BRFIS ACEs module has good information for data collection for community health indicators to track ACEs, and there are many state and local initiatives around this as well. For health departments that are working to promote measurement of ACEs, example indicators might be, the number of trainings that have been completed or the number of providers that are conducting ACEs screenings. Social isolation and loneliness have certainly received more attention lately. I think we might have typically associated this topic with older adult initiatives, but that seems to be changing, I think, especially with all that happened in 2020. So some existing indicators, such as persons living alone or persons engaged in volunteer work, give us broad ideas of what's happening. So we can see that more people are living alone and are less involved in volunteer work, but collection and reporting of data at a deeper level is not quite as consistent. So this is something I think more health departments will be assessing as part of their performance initiatives. And I've included some resources for data collection that you might find helpful. Lastly, measuring community resilience is something that we still grapple with. The National Academies of Sciences, Engineering, and Medicine published a report on this in 2019 and found that while there are many tools out there, none of them measure all key aspects of community resilience, and communities are still not consistently using the tools. So as shown in the graphic, measuring community resilience involves many different parts of a community. And I think this is consistent with public health's focus on cross-sector collaborations. I think some of the key measures that are relevant here are around whether there are cross-sector collaborations in a community, and if so, how many? Are health department staff participating in these collaboratives? Are they able to bring in non-health partners into their efforts? And finally, and this links back to the Barhai assessment, are we empowering community residents to engage in efforts impacting their health? I've noted resilient American communities and accountable communities for health as resources that have really tried to move the needle here, but I'm sure there are many more that we can discuss. And the last major trend I'd like to talk briefly about is, I think, a renewed interest in better integrating clinical and community health data. First, I think we're coming back to the need to understand how well individuals are accessing and navigating our public health system. Understanding health insurance coverage is one piece of this, but it's really not the whole story. I've been working locally on an initiative to better get a sense of ease of access and quality of services. And these are some of the indicators that we've been looking at to understand our system. We're all probably also seeing many communities invest in community resource referral platforms that link individuals to resources addressing social determinants of health, such as food or housing services. I think there will likely be rich data to come from this. For more information about these platforms, I've included a link to a report that provides a review and summary of the platforms. But as these are getting built out, I think the health department's work is probably to facilitate optimal systems. So for instance, working to increase the number of providers conducting screenings about social determinants of health and helping to ensure that these referral systems are robust. And finally, one thing we've increasingly heard across our clients is that there's a lot of clinical and community health data collected, but not a great way to integrate those in a way that makes sense. So meaning we're still having trouble understanding the community context of individuals in a clinical setting. We at HCI are big advocates for this and think this is really the next frontier, helping clinical providers, including health departments, see their data alongside community health data. And I think this can really help to multiply the investments made by individual organizations on community health. Thank you so much for your time. I've included my information here, and please feel free to contact me with any questions. That concludes my presentation. I think I'm going to hand it over to Kelly.
Hi, everyone. Can you hear me okay? Can someone verify?
Yep, we can hear you, Kelly.
Great, thank you. You can see my screen?
Yep.
Yes.
Great. Thank you all so much. Well, we're really excited to be here and present this information to you today. I am Kelly Watkins. I am the epidemiology supervisor here at the Southern Nevada Health District. And so I just want to jump right in and explain our background and really what we've been doing for COVID-19, how we've been working to kind of integrate and merge different indicators and really stay on top of the pandemic, but also make sure that the data that we are collecting is quality, that we're able to pull from different resources and actually translate it into action of some sort. So to give you a very brief background of what our local structure here does look like, we have a centralized surveillance system known as Trisano, and it's open source and it's been extremely flexible for us. And so this is where the majority of our data comes for COVID-19 for case and contact investigations. And it's very robust. So we have access to a lot of local hospital EMRs. We're able to conduct case and contact tracing into one system. We're able to connect it to vital records and do daily reviews and basically keep on top of all of that information and integrate it daily. And we have an extraordinarily, really, it's an extraordinary connection for our ELR. I think every major hospital and clinic within our area does feed directly into Trisano. And so we've been working also to get some additional hospital information in there, all of which has been kind of ongoing even before COVID-19 hit. So we're really proud of this system, but then more or less, we've also been very proud of how we've been able to adapt it. And so this has a direct connection. It feeds directly into our dashboards. We have multiple dashboards. We also support the state dashboard. We also are able to produce daily, weekly, and pretty much ad hoc reports at whim. And we're also able to work on automatic notification using this system, which I'll get into more detail. We've also been able to develop local apps for data collection and symptom monitoring. And then we also were able to conduct a needs assessment based on some new resources that we had from the pandemic. So I'm going to talk about each of these and kind of go into more detail. So one of the things that we needed to do, and we were able to respond to that call, is to come up with some non-traditional data sources so we could actually have some innovative disease investigation support. So the way this works for us is, again, we have our centralized Trisano system, but we typically have disease investigators who do case notification. Obviously, we have, I think now we're over 200,000 cases cumulative that have been in our area. And so we don't have enough people, you know, if we recruited everyone under the sun, it'd be almost impossible to notify people immediately. So in order to have that disease investigative support, we built an automatic system so we could actually notify cases automatically. From there, so we know traditionally we have a case interview that occurs. We're able to actually send out a basic case survey where they can input that information. So the case can input that very basic information, demographics, some key indicators, and also their contacts. And then we basically are able to do a contact notification automatically. And then also we're able to monitor contacts. Now, anyone that's been involved in this pandemic knows that it changes and pretty much has changed daily since. So a lot of this has been in response to needs at that time, and some of it is ongoing. Okay, so we were able to automate these two processes, case and contact notification. We have an online survey now. Now, this is not in place of traditional disease investigation, but it's a way for us to increase the completeness of our data. And then we were able to do a self-monitoring app. So what does this mean? So one of the most difficult parts, I think, of this pandemic is longevity. We know that we have an intervention. That intervention is notifying cases immediately so they can begin isolation, and also making sure that there is that competency there. They know what isolation is, they have the resources available to them, and then also on the contact side that we're able for them to notify, they know their status, and then we can notify their contacts as soon as possible. And so some of this is a balance, you know, what data do you need? What is the most important? But then also making sure that we do the intervention. And so our system is pretty simple. We're able to use Trisano, using these existing Trisano records, which has, again, I think pretty much every lab, that might be a slight exaggeration. We still get some faxes, but we really have a robust laboratory reporting system. And so we take data from these two systems, and we're able to send this automatic email or text message. So from there, they can log on, they can view the notification, and they can actually submit this investigation survey. And so it's in English and Spanish, and to complete the loop, the data feeds back into Trisano, which we can then use for monitoring and reporting. And this also alleviates the burden of our disease investigators by basically changing what queue they'd originally be in, and it does go into the low priority queue. So contacts is pretty simple as well. So they're sent as soon as that information is identified. They can be sent just an automatic email or text message where they get that notice that they had an exposure, what the quarantine requirement is, and they can also link to our webpage, which basically just gives additional information that they might need. And again, it's available in English and Spanish. So in the very beginning, when we were kind of in the unknown and lockdown had first started, we were also under the obligation to continue collecting data on contacts. So this is when laboratory data, labs weren't as available. There was really strict criteria to get that laboratory testing. So we needed a way to continue follow-up if a contact developed symptoms, and then actually have that follow-up come through to see what are your symptoms, arrange testing, and basically complete that loop. So we developed this symptom monitoring app because originally it was 2 calls per DIS per day to basically follow up and see how the contacts were feeling. And so we had a core app created for Ebola when Ebola first rolled out. And we basically retrofitted that to monitor COVID contacts. So it's pretty simple. They can opt in. So they're talking to the disease investigator. They can either opt in or opt out. If they opt in, they basically sign up for this app. They have no symptoms. They just keep looping until the end of their quarantine period. If they have symptoms or they're not responding to the app, we developed 2 lists, and we would follow up on these lists to basically alert a contact tracer and then make a phone call. So this is what it looks like. Because we know that people need to have access, and not only be able to have access to a phone or to be able to download this app, but also understand the questions, we worked really hard to keep it as simple as possible. So they can monitor themselves twice a day and submit this exact same questionnaire. It's just 2 questions. And they can basically do household and or individual monitoring. It was available in English, Spanish, and simplified Chinese. And this information was then extracted into a SAS library. Now, one of the things that would be very beneficial and was talked about, but just due to time constraints, we couldn't accomplish, we do want to feed that data into Trasano eventually, but at the time it was not a direct link back. So it was really great because it didn't just expand our capacity, but really it allowed us to timely notify cases and contacts despite this large case count. And really it allowed for data collection despite the fact that we did have this lag and we have a large queue of cases that our investigators can't get to. The limitations, just linking back to what Jane was saying, we know that we can't reach all of them, but most importantly, they must have an email or cell phone. They need to be able to have a reading comprehension level, and there are limited language options. And so we know that there's some great benefits to this, but we know that some of the most vulnerable in our community might still struggle and need other interventions. So just to show you very briefly about what the impact of being able to launch these kind of innovative data collection methodologies is. So this will look familiar to, I'm sure, pretty much everyone on this call. Daily dashboard updates is something that I can tell you we locally aren't accustomed to doing. And that's a lot of data to clean and collect and organize daily. But because of how our system is very robust, we can adapt it and we can extract that data, not easily per se, but we can do that on a daily basis. We're able to feed from Trasano directly into these dashboards. And that is something that the community both uses and also allows us to track some basic indicators. We also are able to do multiple reports. So one of our new reports lately was our health disparity report. This is just a snapshot where we basically can monitor what's going on in our cases and see how it compares to what we expect in the population. And so we can easily identify that there might be just some hints that we really need to look more deeply or really target, and whether it's testing or resource access or vaccination, use it for planning purposes. And then one of our last things that we just wanted to emphasize is how do you translate this into not only long-term understanding of the impact of COVID-19, but also really be able to reach people and either collect more data and or link them to resources. So we need to know who to reach. And then from there, we need to understand what we can do to help them. So we have the Nevada Resilience Project, where we locally have 4 resilience counselors, one who is Spanish speaking only. We've referred in 1 month, so in December, almost 150 persons. And it's a short-term grant-funded disaster relief program. So the point is that we can refer people to the Nevada Resilience Project. The Nevada Resilience Project can then follow up and actually see what are the needs of the community. What resources are they identifying? So this is ongoing. We don't have much data outputs yet, but it's a way for us to actually link. Somebody says they need something, we are able to make that connection and then actually find the resources. We also have done some work based on our data system to identify high-risk populations, work with the homeless population, create a non-congregate shelter, and really just be able to respond to community needs and requests. And so just to wrap it up, for lessons learned, I think that we really have struggled, but we've also stepped up into that struggle, just in the sense that we know that there's a lot that we need to work on, and that does have implications for community planning and just tracking our performance indicators. You know, messaging is important. This comes back to a lot of trust and building relationships. People are getting bombarded. They might think things are messaging or our apps are a scam. We know that vulnerable populations lack equipment to either use the technology appropriately and or respond appropriately, so then we can basically reach out to them as needed. So that's been, I think, a big hurdle for us, is we're moving so quickly and have so much pressure that we really haven't been able to resolve some of these issues. Data translation is extremely difficult. There's a lot of data going from a lot of different places. There's a lack of understanding of our role, what methodologies we use, what the data can and can't mean, and how we basically continue this in the long run. And situational awareness. We really have lacked existing labor force, training, and infrastructure that's severely limiting. So it doesn't matter if you have a lot of robust tools if people don't know how to train, collect data, or use it properly. And then just coordination with the state. It's a lot of just daily work to make sure that everything that's going out is clean, accurate, and connects the way that we want it to connect. And even just using simple things as making sure we're looking at the right population, that we're looking at the same population, can have important implications. And so that's about it. I just wanted to thank everyone on my staff. We are just completely involved in this and really overwhelmed, but they've really kept going. And especially for this presentation, just the following persons. You know, our IT department at Informatics has worked greatly with us to make sure that we get this technology out. And then our health educators and EPI and of course our disease investigators and contacts have worked significantly on these data. So that's about it.
Thanks so much, Kelly. We'll go over to Stacy next for the final presentation.
All right, thanks, Megan. Can everyone hear me okay?
Yep, sounds good.
And is everyone seeing my slides?
Yep.
Okay. And thanks, Kelly. That was a really great, that was some great information. I think that's helpful to know what other local health departments are doing. I have been working with Conduit and Jane's team, and Jane spoke earlier about what HCI and how she was actually a client of HCI's. And so here I sit as a client of HCI's. And we were set to do our community health assessments. And of course, we're in the middle of COVID-19. And so about a year ago, as we're talking about everything that we need to do to kind of plan for our upcoming assessments and how it's going to work with COVID-19 and how do we do these assessments, which are traditionally done in a group setting with all of our partners and inviting key stakeholders, and everybody sits in a group together and collaborates and listens to each other's ideas. How does